Welcome back. We continue to explore the reactive patterns of the dermatitis, and last time we covered the spongiotic and the psoriasiform, and today we will cover the lichenoid reaction pattern as the main category, along with the vesiculobullous, that they happen in the dermal epidermal junction. As a definition, always when you hear the word lichenoid, always think of basal cell damage and interface dermatitis. If you look into Weedon's chapters, he divides the chapter into three areas: the lichenoid interface dermatoses and the poikilodermas and the other lichenoid interface diseases. So just before we start, we would like to kind of like put in perspective some definitions, because we're gonna encounter this along the chapter. So it's better to kind of keep those definitions straight as you are learning this chapter. So CVAT bodies, and CVAT was a French dermatologist, and there are a lot of diseases were named after him. We mean by CVAT bodies is basically the apoptotic cells that we see in the epidermis, and that happens usually either scattered along the basal cell layer, or entire epidermis will have those cells. So whenever you see very eosinophilic with atrophic or pycnotic or dark nuclei, think of apoptosis or this keratosis. Those all terms mean the same thing, or CVAT bodies, meaning the cell is dying. And the mechanism happen because of ICAM1, or intercellular adhesion molecule, that is expressed in the keratinocyte. So when this molecule is upregulated, it will attract the lymphocytes, and the lymphocytes will destroy the cell, or will start the apoptosis of the cell that caused the damage to the keratinocyte. There are a lot of studies to learn from, especially the one that came in 1995 to discuss the difference between SCLE and EM and LP. If you want further reading, you can start learning about those different entities via like the mechanism of ICAM1. So lichenoid interface dermatoses, there are many, and we will not be able to cover all of them in 20 or 25 minutes, but I would like to give you just like the basics as always, and hopefully in the future we can explore more entities, and some of these entities we will discuss in details in other chapters. But I like to think about lichenoid interface dermatoses in three categories. The first category is the lichen planus features, and we will talk about those features in details, and the diseases that happen because of medication or because of like damage that is related to medication. So except for erythroderma multiforme, because I know like the disease mainly happen because of less commonly because of medication. The rest of these diseases happen because of medication, and I group those diseases together when I study or when I encounter those cases. The third group is the connective tissue disease group. Those are together, and we'll start with the main kind of like the name, where the name came from, the lichen planus, and we all remember from our medical education about the clinical features as they appear as itchy, villous eruptions. Sometimes they have the Wickham striae, and this is like this whitish network, fine lines on the surface of the papules. Many people have tried to explore those like Wickham striae, which were named after Louis Frederick Wickham in 1995, who was a French pathologist. I like to explore the names of the different entities, and you will see in those series I tend to list the names or the pictures of the scientists who these entities were named after, because I feel like it will help me to kind of tie the name to the person, and also like to explore more the history behind the name. So Darriere, which we will hear more about in the future, describe those striae based on the granular cell layer mechanism or etiology, and he said that we see increase in the granular cell layer. Other people they found that there is increase in the epidermal activity for formation or dermal vessels in the area, which acts as contributing factor, and the histologic confirmation for those is done usually by India ink, and we see the India ink is retained in the stratum corneum. Lichen planus usually is associated with many diseases, and some of those diseases are viral, especially the hepatitis C, which is like commonly tested on the board, some vaccination like influenza, and some other autoimmune diseases. The pathophysiology that we know so far about lichen planus is usually happen in relation to the HLA-DR and the cytokeratin 13, 8, and 18, which the main player is CD8. Doesn't mean other lymphocytes or other markers are not involved, but the main cytotoxic CD8 etiology is kind of predominant in explaining the lichen planus pathophysiology, and we talked about this in terms of like the idea of ICAM1, that it will increase the apoptosis, and because the BCL2 is anti-apoptosis, it will increase in lichen planus as a reaction to the increase of apoptosis activity. Also, like we need to know about the different types of like HLA-DR that is in relation to lichen planus on chromosome 6. So the familial type is usually found in HLA-B7. The non-familial type is usually found in HLA-DR1, and the one that we see commonly with hepatitis C is usually found in relation to HLA-DR6. So as always, I like to start with the normal skin and then show you what happened in cartoon, and try to understand the histology before we look into real images. So in lichen planus, we see band-like inflammation that basically obscuring the dermal epidermal junction and spreading apart from the epidermis, making the epidermis thin at the end, making it look like the tips look like a sawtooth pattern, as we see here. And also we see the CVAT body or the keratinocyte, dyskeratotic keratinocytes at the base. And I want you to take note, like now up until the end of the chapter, because this concept is gonna repeat itself as we study the different diseases. I want you to take note like where we see the dyskeratotic cells. Do we see them at the base, or do we see them above the base, or do we see them the entire epidermis? Because each disease has different kind of features, and it will help you to understand the severity of the disease or like the category of the disease if you make note about those different patterns. So the second thing we see is the colloid bodies, and those are usually stained with PAS, pink color, usually found in the superficial dermis. And another thing is the granular cell layer will look like wedge shape because of the hypergranulation, will make like a wedge shape form in lichen planus. And this is just images from histology to show you those patterns. As you see the inflammation, we see like from low power this keratosis, and we see also the it changes, the vacuolar changes in the basal cell layer. Here is more we see on this image. On DIF, direct immunofluorescein, usually the most important differential diagnosis, especially on the scalp, is the SLE, and DIF usually helps with those differences. LP, usually we see IgM and fibrin band in the dermal epidermal junction. In SLE, we see the linear deposition of immunoglobulin and C3 in linear fashion, but if you go on high power, you will see it as granular or punctate pattern instead of the straight line, especially in the apoptotic bodies. So there are many variants of lichen planus. We will not be able to cover all of them, but just like try to tie the name to the variant. So in atrophic, it means just the lesion has some atrophy. In hypertrophic, basically the lesion is hypertrophic. Annular, the lesion looks circular. Linear looks linear. Erosive or ulcerative, oral, and different other variants. So if you understand the concept of lichen planus, the variants, they have the same kind of pattern, but we may see like a little bit different in terms of the location or in terms of the clinical, or sometimes the severity of the disease is less common. So just few examples of the annular and also the circular. Sometimes they are tied together, where we see the central atrophy, the villous plaque, and like we see in lichen planus. And also on histology, in addition to the features that we see in lichen planus, we see here the thin epidermis, where the reedy ridges are flat, with the inflammation is less severe. Another example is the hypertrophic. As you see here, the lesion is hypertrophic, and in this lesion we see the epidermis looks hypertrophic, where we see like hyperkeratosis and psoriasiform hyperplasia, in addition to the vacuolar changes and the other features we talked about in the lichen planus. Lichen nitidus is nitidus in Latin means clear, and the reason why is called nitidus because clinically they are small flesh colored papules. On histology, they have the unique feature of the reedy ridges. They form like a claw pattern that holds the well circumscribed subepidermal infiltrate. Usually they say is limited to 1 or 2 dermal papillae, but sometimes more. Other thing we see in lichen nitidus is the parakeratosis, and these keratotic cells are at the base. Sometimes we see in the inflammation area giant cells, and this is just an example where you see the reedy is forming like claw around the well circumscribed inflammation of the subepidermal. Lichen nitidus usually affect the male population. We see it in eyebrows and the tongue, commonly found chest, abdomen, anal, genital area, and extremities. We have two forms, either the localized or the general. Also, there is association with Downs. When it affects the nail, it will cause longitudinal splitting. The etiology is unknown, and dermal lymphocytes usually have different markers than LP, and when you do diff to differentiate it from LP, usually diff is negative. Lichen striatus, also, like the clinical picture, is unique because the linear papular eruption on one side of the body. On histology, we see acanthosis with parakeratosis and dyskeratotic cells in the basal cell layer, in addition to the well circumscribed inflammation in the superficial dermis, like lichen nitidus. Here, the other unique feature is the peri-adnexal inflammation around the sweat units. That's like a unique feature for lichen striatus, in addition to the other features what we said about. The main cell type we see in lichen striatus is lymphocyte. Doesn't mean we will not be able to see like other type of cells, but lymphocytes are usually the most common. So we finished the first group, or the lichen planus type of lesions, and we will move on to the lichenoid lesions that are related to medication or infection, like erythema multiforme. But before we do that, I just want to say briefly about LPLK, or lichen planus-like keratosis. And this is like one of the very difficult situations, and you will see, like when you look under microscope, most of the time you will see atypia at the base, and especially like when you are trying to see in shave biopsy whether this lesion is AK versus LPLK, you will notice that the atypia at the lesions at the base, the basal cell layer, is usually restricted to the inflammation area and the superficial dermis in these lesions, whereas in AK the dysplasia will be like along the inside the or around the inflammation and outside the inflammation. So it's important to differentiate between LPLK, which is like the benign kind of form, or the AK lichenoid, which is basically pre-cancer. So if you want to do that, focus on the area where the inflammation is, and when you see the dysplasia is restricted where the inflammation is, this is usually LPLK. But when the dysplasia is kind of like hitting all the basal cell layer without differentiating between areas that has inflammations or areas that don't have inflammation, and that's very important for those lesions. So moving on, for those like the medication related lichen planus lesions, and I want you to think of those lesions as stepwise pattern. So we start with focal parakeratosis with some cells that have vacuolar changes at the base. We see EOs, which is like hallmark for medication related dermatoses, with some plasma cells in non-photo distributed areas, and we see the dyskeratotic cells now start to appear above the basal cell layer. Like this example, this is lichenoid drug eruption, which is like the least or the mildest form of those drug-related lichenoid lesions. Moving upward on the scale of severity, we start seeing focal parakeratosis with more now dyskeratotic cells upper than the basal cell layer, with more basal vacuolar changes and more eosinophils, and this is where we see a fixed drug eruption. In addition to those features that we saw in the lichenoid we see superficial and deep perivascular inflammation, and the type of cells here in the superficial and deep will be neutrophils and lymphocytes. Moving on, we see lichenoid pattern in addition to the vacuolar changes at the base, but here the vacuolar changes will look like they are trying to make a split between the epidermis and the dermis, in addition to more dyskeratotic cells. And here we start seeing those dyskeratotic cells in the entire epidermis, and in addition to those features, we see less in this lesion eosinophil. If you did diff on those lesions to try to differentiate between lichenoid type lesions or vesiculobullous type lesion, you will see the intraepidermal IgM is basically concentrated with CD3, or sometimes you see the C3, or sometimes you see the C3 at the dermal epidermal junction. So this is erythema multiforme, and when you see that this clifting more severe that caused the epidermis to split from the dermis, in addition to epidermal necrosis, this is usually the more severe form of the erythema multiforme, which is TEN. So these are just clinical examples. The first one is the lichenoid drug eruption, where we see scaly rash in photodistribution area, and the fixed drug eruption, where we see well-defined red patch or plaques in addition to blister or ulceration. And the last one is erythema multiforme, where we see sharply demarcated lesions that have the target sign, sometimes macule or papule, or sometimes larger plaques or patches. Graft-versus-host disease depends on the severity of the lesion, and also depends on the time of the lesion. In acute lesion, we start seeing lymphocytes along with vacuolar changes at the base with some dyskeratotic cells, but now the dyskeratotic cells is filling the entire epidermis, along with the satellite cell necrosis. Satellite cell necrosis, we see the dyskeratotic cells surrounded by 2 or more lymphocytes, and depends on the degree. The grade 1 graft-versus-host disease, we see grade 0, we see only normal skin. Grade 1, we see basal vacuolar change. In grade 2, we will see dyskeratotic cells in the epidermis, the follicles, along with dermal lymphocytic infiltrate. In grade 3, we will see the fusion of the basilar vacuolar changes to form a cleft and microvesicles. In grade 4, we will see the separation of the epidermis from the dermis. These features can present the same in chronic form, in addition to the melanophages that we see in abundance in the superficial dermis. If you do DIF staining for those lesions, you will see IgM and C3 are concentrated at the colloid bodies. Those forms, the chronic forms, can develop into the sclerodermoid phase, where you see the collagen sclerosis in the dermis, in addition to the other features. So we covered the first two, the lichen planus or lichen planus features, the medication related diseases, and now we're moving on to the connective tissue related diseases. So we start with discoid lupus or tumid. Usually those are connected to each other. Tumid means swollen, and in these lesions we will see the follicular plugging and we will see the vacuolar changes around or concentrated around the follicular unit. Doesn't mean we will not see vacuolar changes along the basal area, but more concentrated around the hair follicle unit. In addition, the cell type will be inflammatory cells, mainly lymphocytes, and we will see this keratotic cells or CVAT bodies kind of spread apart or like scattered. In addition, we see colloid bodies, and the basement membrane will be thickened, and this is sometimes is more appreciated on old lesion. When you do PAS staining, you will see increased thickness of the basement membrane. Hyperkeratosis is another feature you will see in those lesions, and the dermal mucin, you can see it on sometimes on H&E you can appreciate it, but more commonly people do colloidal iron. I don't know how much use for colloidal iron, because sometimes, especially on lesions that in sun exposed skin, when you have solar elastosis and you do dermal mucin, it's hard to differentiate between whether this is increase in mucin or just like this is a solar elastosis. But at least in the studies that they say if you do colloidal iron is useful to appreciate increased dermal mucin. In addition, we see superficial and deep perivascular inflammation, and the main cell for these inflammation is the lymphocyte. If you do DIF staining for those lesions, you will see IgM and IgG, and usually they are concentrated at the basement membrane. And in the book, the recommendation is to try always to correlate with the clinical picture, because sometimes those results are variable, not always we see those results are positive at the basement membrane. So this is just an example of discoid lupus. Intumid lupus is much less severe than discoid lupus, and you will not see the lichenoid interface dermatitis that we see in other type of lichenoid reaction. You will not see the band-like interface dermatitis, but you still see superficial inflammation with some vacuolar changes at the base. So moving on, lupus erythematosus has different variants like all other diseases. We will not be able to cover those in details. We spoke about the discoid. The subacute form is usually clinically is more appreciated as wide non-scarring photosensitive rash, where on histology you see the other features like lichen planus, basal vacuolar change, and epidermal atrophy, and dermal edema and superficial mucin will increase. The systemic lupus usually is systemic disease, and you have other tests you can diagnose the disease. On skin biopsy is not different from other forms, and you cannot give systemic lupus erythematosus diagnosis on skin biopsy alone. In the neonate form is very rare, usually affects neonates, and the bullous form usually on clinical you will see the bullae formation. Paniculitis is called profundus because usually affects the deep layer of the skin, and it will be covered in the paniculitis chapter. So moving on, the dermatomyositis, and this is another disease that is systemic, that affects the muscle and affects the skin, and usually is very difficult to diagnose this disease on skin biopsies alone, because the changes are very subtle, and if you don't have the muscle biopsy results, it's hard to make that call on skin biopsy alone. So usually we see the vacuolar changes at the base, along with colloid bodies and dyskeratotic cells or CVAT bodies, with increased thickness of the basement membrane, superficial perivascular inflammation, and superficial inflammation mainly by lymphocytes. But the important feature, and I think on H&E you can appreciate this, and we will see this like in our unknown cases, that you see the increased dermal mucin in the dermis. If you biopsy Groton's papule, you will see hyperkeratosis and mild acanthosis, and this is a helpful feature along with the other features to make that call. This is just an example of the dermatomyositis, the skin biopsy, where you see the vacuolar changes here. On this example, we are unable to appreciate increase in mucin, but the lichenoid reaction pattern, along with the clinical history, should be consistent with those changes that we talked about in dermatomyositis. So we finished the lichenoid lesions, and we move on to the poikilodermas. Those diseases are usually have like a unique kind of pathophysiology and unique kind of feature, where we see hypopigmentation with hyperpigmentation, along with the telangiectasias and atrophy. And I think the telangiectasia feature is the most kind of helpful along with the other features, because this feature is unique to this type of disease, but when you see like other signs, is hard to kind of put all of them together, but the telangiectasias will help you to make that diagnosis. So on histology, we see hyperkeratosis with epidermal atrophy, basal cell vacuolar changes, with rare basal keratinocytes. As we said, the telangiectasias, or the increased blood vessels, dermal macrophages, and variable upper dermal inflammatory cell infiltrate. Those lesions are divided into three categories. The first category is the genetic type of conditions. In the past, it was not a separate category, but now mycosis fungoides, early lesions, is considered a separate category in terms of the poikilodermas, and the variant that is related with dermatomyositis and less often SLE. And the final category is the one that has like kind of waste basket that have different features. The one that we have the post-radiation, cold and heat, prolonged exposure to sunlight. This is the most common poikiloderma of CVAT, and the one that is related to medication or GVHD. So we'll talk about those in details. We'll start with the first category is the genetic category, Rathmund-Thompson syndrome. It was named after German ophthalmologist and British dermatologist, and this is an autosomal recessive disease where we see osteosarcoma. The problem with those conditions is related to aging, and DNA helicase usually because of mutations in those genes, we see a problem in the DNA replication. As you see here, the skin looks like old in those children, and that's the problem with those types of diseases, as the DNA is aging very fast. The other one is this keratosis congenita, and this one we see the nail dystrophy along with the abnormal pigmentation and also the leukoplakia of the oral mucosa. The mechanism is short telomeres, and usually we have premature aging, in addition to progressive bone marrow failure and early mortality. The most common Poikiloderma is the Poikiloderma of Civat, and this is we find more commonly in light skinned females, is related to the telangiectasias of the skin, where it appears as a reddish brown discoloration on the neck, most commonly on both sides, and the blood vessels here is dilated, and we see also melanin incontinence. Sometimes we see a mild atrophy of the epidermis. Sometimes also we see vascular changes along with the sparse perivascular lymphocytes. It was named after French dermatologist Civat. And finally, this is the other lichenoid diseases. As you see, is very long chapter and has a lot of entities. We will not be able to cover those in 20 minutes, but I would like to talk about just today the lichen sclerosus atrophicus and psoriasis lichenoides, and those very important to cover those today, but the others I think some of them we covered in other chapters, and some of them we will talk about in other chapters. So hopefully we'll be able to cover the majority of those conditions. So the first one is lichen sclerosus atrophicus, and this is like clinically just an atrophic lesion that initially there was an inflammation, and on histology you will see in early lesion there is inflammation mimicking lichen planus and vascular changes and apoptotic basilar keratinocytes, and as the lesion progresses the inflammation will be pushed down, and there will be a zone of edema and sclerosis kind of occupying the superficial dermis. The other one is also very commonly tested on the board exams, the PLEVA, and this is an acute form of lichenoid reaction, usually clinically resemble smallpox, because there is like an ulcerated small papules that happen suddenly on the trunk. On histology, we see the other features that we saw previously. We see a compact hyperkeratosis, focal parakeratosis, but the main thing here is to remember the neutrophils. In addition, this keratotic cells, vascular interface dermatitis, and the dense wedge-shaped mix infiltrate with lymphocytes, exocytosis, and usually no eosinophils. As we said, the neutrophils with dermal vessels and the erythrocyte extravasation. This is a nice example of PLEVA. In acute lesions, we will see the epidermal changes with parakeratosis, hyperkeratosis, and lichenoid-like reaction pattern where there is band of inflammatory cells blocking the dermal epidermal junction, with the keratinocyte necrosis and interface changes. If you have a high magnification of this, you will be able to appreciate the red blood cell extravasation, the vascular changes, and the other features we talked about earlier. So just before we end, the memory tool for you to remember, when there is a vascular change in the base or above the base, always think of lupus, dermatomyositis, drug, and poikiloderma. The band-like inflammation we see in erythema multiforme, fixed drug eruption, pityriasis, lichenoides, paraneoplastic pemphigus, lupus erythematosus. The deep perivascular inflammation we see more commonly in lupus, in syphilis, drugs, and photolichenoid. And satellite necrosis we see in graft-versus-host disease, eruption of lymphocyte recovery, erythema multiforme, paraneoplastic pemphigus, regressing plan, warts, and drug reaction. This is the end of the chapter. Thank you for listening, and we'll move on to see some unknown cases related to this chapter.